Exercise intolerance afflicts most patients with heart failure regardless of left ventricular ejection fraction. Exercise capacity can be measured objectively as peak oxygen uptake, or VO2 peak, and values in heart failure are often less than 50% of what we see in healthy age-matched controls. And patients' quality of life and survival correlate more closely to VO2 peak than to other objective biomarkers of heart failure severity. And so from both the patient and clinician standpoint, alleviating exercise intolerance remains an urgent unmet need and underscores the importance of understanding more fully its causal mechanisms. A range of disturbances, including abnormalities of cardiac, vascular, pulmonary, and skeletal muscle reserve, have been shown to limit exercise in heart failure. Remarkably, however, the hypothesis that augmented sympathetic vasoconstrictor input to skeletal muscle resistance vessels, or muscle sympathetic nerve activity, might also constrain exercise capacity by impairing the normal vasodilator response to exercise has received relatively less attention. So our laboratory's research, principally in patients with heart failure with reduced ejection fraction, has yielded novel evidence linking exercise intolerance to sympathetic activation. Our first finding was an inverse relationship between resting muscle sympathetic nerve activity and VO2 peak in patients with HFrEF that was absent in age-matched healthy controls. In response to one-leg cycling exercise, a more symptom-generating activity in heart failure, vasoconstrictive MSNA measured from the opposite resting limb decreased in healthy controls during both mild and moderate intensity one-leg cycling, yet increased paradoxically in patients with HFrEF. And as you can see on the right, we saw an inverse relationship in HFrEF between the change in MSNA elicited by one-leg cycling and VO2 peak. And so this was suggestive of a sympathetic neurogenic vasoconstrictor constraint on exercise specific to HFrEF patients. And so the present objective was to determine whether this disturbance is specific to HFrEF or whether it is evident in all with heart failure across the left ventricular ejection fraction spectrum. We studied 55 heart failure patients with an ejection fraction ranging from 15 to 73%, and 49 healthy normotensive volunteers. We measured heart rate, blood pressure, and muscle sympathetic nerve activity during our one-leg cycling exercise protocol, which consists of 2 minutes of rest, 4 minutes of one-leg cycling, 2 minutes each at mild and moderate intensity, and 2 minutes of recovery. And VO2 peak was determined from a standard graded exercise test. As anticipated, we found that both resting MSNA burst frequency and burst incidence were higher in heart failure patients versus healthy control, and both relative and percent predicted VO2 peak were lower in heart failure patients versus healthy control. In response to one-leg cycling exercise, in the healthy control group, we once again saw a reduction in MSNA burst frequency in response to both mild and moderate cycling, whereas in the heart failure group, we saw an increase in burst frequency during mild and moderate cycling. And on the right panel, you can see that MSNA decreased by about 5 and 6 bursts per minute in the healthy controls, yet increased paradoxically by approximately 5 and 5 bursts per minute in patients with heart failure. And so you can probably appreciate that inter-individual variation responses we see in the heart failure group during moderate cycling. And so we wondered if this might relate to phenotype or ejection fraction. What we found was that the MSNA response to one-leg cycling was unrelated to left ventricular ejection fraction. This paradoxical sympathoexcitation was evident in most patients across the LVEF spectrum. What it did relate to, however, was exercise capacity. First, though, on the left panel, we saw no relationship between the change in MSNA burst frequency during exercise and either relative or percent predicted VO2 peak in healthy controls. Whereas on the right panel in heart failure patients, we saw that the change in MSNA burst frequency on the x-axis related inversely to both relative and percent predicted VO2 peak on the y-axis. And so those patients with the greatest sympathoexcitatory response to exercise had the lowest exercise tolerance. And so unlike healthy individuals, dynamic exercise stimulates a paradoxical sympathoexcitatory response in most patients with heart failure that's independent of ejection fraction. And our findings offer unifying evidence for a neurogenic vasoconstrictor limit on exercise regardless of phenotype. And finally, our findings offer the potential to alleviate exercise intolerance in all patients with heart failure by blunting maladaptive sympathetic excitation during exercise, whether via exercise training, pharmacotherapy, and/or device-based therapy. Thank you.